Bismillahirrahmanirrahim. My name is Uzair Ali and currently I am working as project coordinator. I am very thankful to all of you for joining. We can see people joining from KPK, from Punjab, from Sindh, and more will be joining soon. We are highly esteemed to have Professor Javed Iqbal Farooqi, who is a renowned consultant gastroenterologist and hepatologist. And he is currently working at Al Hayat Hospital, Peshawar. So, sir, can you please take over the mic and introduce yourself and go carry on with your slide deck, please, Professor Javed Iqbal Farooqi Sahab. Then we will go towards the case, and after that we will go towards the question answer session. Thank you.
Thank you, Mr. Uzair. Thank you very much for your kind invitation. I am the Professor Javed Iqbal Farooqi from Peshawar, and I'm thankful to the Dr. Asad Chaudhry and the whole PARSA team for inviting me to have this lecture on the series of the hepatitis B. I'll share my slides with you. Can you see my screen?
Yes, sir, we can see your screen, but it's curriculum hepatitis B.
Yeah, this is my first slide. So, well, so should we start?
Yes, sir, please carry on.
Okay, Bismillahirrahmanirrahim. I'm showing this for the reason that we are in the chronic hepatitis B curriculum, and prior to my this lecture on hepatitis B serology tests and their interpretation, we had lectures on the HBV epidemiology and then the clinical features. And the next week, the same time, probably the same time, we will be having the main lecture that will be whom to treat and how to treat. So in my lecture, what I will do, I'll try to give concepts of the hepatitis B serology, and we'll try to make the ground for the next lecture, that how we can interpret these and what are these serological tests. These are important for the reasons that these tests, they determine if treat or not to treat any particular patients with chronic hepatitis B, and if treat, then how long. So these are very important and basic determining factors in the clinical practice of treating chronic hepatitis B patients, and probably this is the reason that this has been given a separate topic. Well, before going to the main discussion, what I will do that I'll share with you one basic pathological fact. We all know that the inflammation, when we were reading the chapters of on inflammation, we knew that acute inflammation was something, the resolving phenomena. It used to resolve within weeks or maximum days or weeks. But on contrast to this, the chronic inflammation is a progressive phenomenon and may exist for weeks or months or even years, and at times lifelong, like autoimmune inflammations. And another point which we know, that the chronic inflammation is specific because it has got inflammation as well as a component of healing. And the component of healing is by fibrosis in most of the cases. And as this chronic inflammation persists, this amount of fibrosis increases from no fibrosis to F1, F2, F3, and F4 fibrosis. F4 fibrosis is the maximum fibrosis which distorts the liver parenchyma, and when it reaches, it leads to appearance of regenerative nodules, and this is called cirrhosis. So F4 fibrosis and regenerate nodules will be technically called as cirrhosis. The amount of fibrosis we know from our pathology, it depends upon the rate of formation and rate of removal by the natural mechanisms. So if the formation is greater than the removal, with the passage of time, what we will get these results, the gradually increasing amount of fibrous tissue in the liver, and this formation depends upon the duration of the inflammation. This is very basic point when I'll be discussing with you the serological tests and their interpretation. This is very important to know that. In chronic hepatitis B, it has got two phases. At times, it is non-inflammatory phase. Infection is there, but there is no pathological phase of inflammation, and the inflammatory phase. And this is the inflammatory phase which determines the duration of inflammation. If this inflammatory phase stays for a longer period, it will lead to a lot of formation of fibrosis. And if the fibrosis increases, the cirrhosis will be the ultimate outcome. So the immunity or the HBV serology really plays, and it puts the patient either into non-inflammatory phase or into inflammatory phase. And that's the reason that if we know the concepts, it will be very easy for us to interpret whether the patient needs treatment or not treatment, or in which phase the patient is. Well, we know that it's a major, one of the burden is really huge one. In 2015, out of 1.2 million deaths, the 2.1, the deaths, the 10th cause of the deaths of these was the liver cirrhosis, and it increased from 2000 to 2015 by millions. And this is again the 2015 data that out of the 7.358 billion total population, 328 millions, they were either having hepatitis B or hepatitis C, and the major bulk, 257 million, they were hepatitis B. So that's the reason it is important that we should be very clear about its stage and its whether if the patient needs to be treated or not. This is the basic understanding is most of our colleagues, they confuse hepatitis B with hepatitis C. There's a lot of difference between these two. Hepatitis B, C is curable, and you need to start antiviral treatment in each and every patient. You will avoid the treatment only if it's contraindicated, and the treatment here is short term. This is a cage point that couple of our colleagues, most of our colleagues, they get entrapped, and what they do, they consider HBV like hepatitis C. Mind it, HCV is a curable disease, while hepatitis B is not curable, it's only controllable. In HCV,
one moment.
Whenever,
okay, I found this on the web for his adorable disease.
Whenever you get a patient, you need to treat this patient with the antiviral treatment, while in case of the hepatitis B, you will avoid the treatment, you will start treatment only if it is indicated. Hepatitis B is a lifelong disease. Hepatitis B disease is an invasion of hepatocytes by cccDNA, which stays there lifelong. What do I mean by this? That when this hepatitis B enters the viron enters the hepatocytes in the nucleus, the cccDNA forms, and this forms lifelong. And this is the reason that this is a lifelong disease, which I said. The course of disease depends upon immunological response of the patient. What I mean by this, we all know immunological response means reaction between antigen and antibodies. And here the antigens which are brought by the hepatitis B viron, the body makes antibodies against those. The hepatitis B viron, we know, one is the outer layer, the lipid bilayer membrane, and it contains the HBs surface antigen, which may be a large surface antigen, medium or short, but collectively the HBs surface antigen, this is one of the major antigen which the viron brings into the body, and the body makes antibodies against it. Then going inside the E antigen and the core antigen. The core antigens, they are not detected in lab, while the E antigen, they are detected in the lab. So this is the another sets of antigen which the virus brings into the body. And when we go further inside, the DNA and DNA polymerase, this is the another component which the virus brings into the body. So this is the antigens, HBs antigen, HBe antigen, core antigen, and then the DNA and DNA polymerase. And what, as I said before, what the body responds, it responds by making antibodies against HBs antigen, the HBe antibody against HBe antigen, and in the acute phase, it forms the IgM antibodies against this core antigen, and the long term, it is the core antibodies. So this is the interaction between these antigen and antibodies, which determines that how long the disease or the infection will there in the body, and what will its outcome. If the antigens, they are cleared by these antibodies within 6 months, this is called acute hepatitis B and recovery. But if it takes longer or cannot clear within 6 months, the patient is said to be in the chronic phase, and then it has got its own phases. So with this main background knowledge, as I said before, if these antibodies are formed within 6 months, we call this acute going to be resolved, a recovered case. But mind it, in acute as well as in recovered case, the cccDNA, it persists in the body. This is important. Then the patient, if does not get clear, especially in the early childhood, or those who get this infection from the mother, it can go into a chronic phase. And then it may be there in the chronic phase, or some fragments, they may recover spontaneously or go into that recovered phase or with drugs. But mind it, there may be reverse also, that so-called recovered case may reactivate and go into a chronic phase like that with the immune escape phase. So again here, the cccDNA is the culprit resisting or persisting within the hepatocytes. With this background knowledge, as I said before, if the patient has entered into chronic phase, then this chronic phase has got 4 important biological phases. One is called immune tolerant phase. It is the old terminology. I will explain in coming slides what's its new term. Nowadays it is called HB antigen positive chronic hepatitis B, where it's a high replication of the hepatitis B virus, but the immunity is tolerating it. There is no damage to the liver. There is no onsets of hepatitis. There is no onsets of inflammation. Then the immunity starts reacting, taking again on those hepatocytes which harbor the hepatitis B virus, and this is called hepatitis B, chronic hepatitis B immune reactive phase. It was called, now it is called HBe antigen positive hepatitis. Then what the immunity overcomes the viral replication, and the inflammation cools down, the viral replication is controlled, and this is called immune control phase. In the years past, it was used to be called HBs antigen healthy carrier. They are not the healthy carrier, but this was called 2 decades ago as healthy carrier or the carrier. And then even in this chronic phase, again the replication may start, and this can go to the immune escape phase. So this is the overall view. When we will be discussing the serology, our patient may be falling in this group, acute, or in the chronic immune tolerant phase, or immune reactive phase, or chronic immune control phase, or chronic immune escape phase, or recovered phase. I showed this slide to you to understand what's the underlying, or what's the main basic pathological or serological or virological phases. So if we have this concept, it will be easy for us to put our patients and interpret our serology of the patient to which phase the patient belongs to. So the ultimate clinical outcome is the development of cirrhosis, and then its complications are HCC if the patient is not treated, and the clinical outcome depends upon the phase of the chronic hepatitis B phase. So again, this slide I've shown you, in these 2 phases, in the first phase, that is the immune tolerant phase, and the immune control phase, immunity is inactive. There is no significant liver damage. So there is no acute liver failure. And if in the chronic infection, there is no cirrhosis and no HCC. HCC may happen, but very negligible. But in these two phases, the immune reactive phase and immune escape phase, immunity is active against those hepatocytes which harbor the hepatitis B virons. There is significant liver damage because of the immunological attack on those hepatocytes. It can lead to acute liver failure, and in chronic phase, it will lead to cirrhosis and or hepatocellular carcinoma. So when we understand that in which phase our patient lies, it tells us whether if we treat or if we don't treat. If our patient is the immune tolerant phase or the immune control phase, we will not treat. But if the patient is the immune reactive phase or immune escape phase, we will treat this patient. Okay, so this is the significance where we will, why we need to know the serology, because as I said before, liver damage is the only indication for the treatment, and liver damage is caused when immunity attacks on those hepatocytes which harbor cccDNA, where HBV replication and viron synthesis is happening. So the number one condition will be to avoid liver damage. And when we will avoid, if it is going to happen, and when it will happen, if the patient has hepatitis. And what is hepatitis? What stage? Immune reactive stage and immune escape stage. Second, to minimize liver damage, if hepatitis B virus has already damaged the liver of a patient has come to you, so our aim will be to reverse that damage. And if you cannot reverse, halt that damage. And if you cannot halt, slow down the process of damage. And what does it mean? It means if it is already, the damage has already happened, and this will be either fibrosis and cirrhosis. So we treat patients of chronic hepatitis B hepatitis phase, or if a patient has developed fibrosis or cirrhosis. So these are the main factors, and we know that higher the viral load, higher is the chance of patient developing cirrhosis and hepatoma. So coming to the HBV serology, we have got two antigens, HBs antigen and E antigen, and we have got three types of antibodies: HBs antibodies against HBs, antibodies against HBe antigen, and then core antibodies IgM and total. This is the acute hepatitis B viral infection with recovery, that HBs antigen, it is cleared by the anti-HBs, and the IgM antibodies appears first, then it is followed by the core antibodies, and E antigen, which is positive in the initial phase, it becomes seroconverted anti-HBe happens there. But in chronic, what we see, the HBs antigen stays there almost lifelong. The IgM antibodies disappears, but the core antibody stays there, and the HBe antigen remains there for years, for decades, and very rarely it can go into, it can get seroconverted, okay? So if the patient is in acute phase, this will be the serology we'll discuss later on. And in the recovered, all antigens will be cleared and antibodies will appear, while in chronic phase, depending upon which phase the patient is, immune tolerant, immune reactive, immune control, or immune escape, the serology will differ. So let's see how it will happen. Just, I need your attention for this slide. This is very, very important and basic slides, and I'll try to take each and every phase and discuss how the serology happens here. This is the HBs antigen and anti-HBs, the same color coding which I used here. This is the E antigen and E antibody, again the same code. This is the total core antibodies, and this is the IgM core antibodies. This is the HBV DNA, PCR, and this is the ALT. Basically, serological tests are these, and this is the supplementary test. So for the completion of the subject, and where the Professor Altaf Saab will be discussing with you whom to treat and how long and when, these will become evident and more relevant and evident, and probably it will, he will not take time on these, and he will give more time to the different scenarios. So in acute patient, if a patient has got acute hepatitis B, what the serology will be, the HBs antigen will be positive, and there will be no antibodies because S antigen is there. We will be having E antigen positive, and antibodies has to be negative because E antigen is there. because this is the universal principle. Either antigen will be positive or antibodies will be positive. Similarly, in acute, the core antibodies and total may be positive, and DNA PCR is positive, and the viral load, the ALT is very, very high. But when this patient recovers, what happens? HBs antigens disappears, and it disappears because now the antibody has appeared and it is cleared that HBs antigen. E antigen is negative and E antibody is positive. It is seroconversion has happened. The IgM antibodies is negative core antibodies, and the total antibodies are positive. The DNA is negative, are very low levels positive, and the ALT is normal. So this is contrast, mirror image, acute and recover. So they are the opposite of one another. They are the opposite. The antigen positive, it's negative. Antibody is negative, it's positive. E antigen positive, it's negative. E antibody is negative, here is positive. Core total body positive, remains positive. IgM positive, negative. PCR positive, it is negative. And ALT, which was raised, is normal. So this is a very simple that whatever antigens are with you, we revert them negative. What happens if the patient has not cleared within 6 months and has entered the chronic phase? And I already told you that the chronic phase, there are four, it is subdivided into 4 phases, depending upon the E antigen status and the DNA viral load in the immune reactions. So the very first, and these are the conventionally they were called immune tolerant, immune reactive, immune control, and immune escape phase. In the first phase of the chronic hepatitis B, the first virological phase, which was called immune tolerant phase, HBs antigen has to be positive because this is chronic hepatitis B, and the anti-HBs has to be negative because when antigen is positive, antibody will be negative. The E antigen is positive here, so the antibodies will be negative. It's simple to understand. You don't get confused. The core antibodies is positive, total is positive, IgM is negative, viral load is very, very high, but the ALT is normal. Okay, so this is the immune tolerant phase, and nowadays this is called HBe antigen positive infection. Why? Because ALT is normal. It is followed by immune reactive phase, where the immunity becomes awakened and attacks those hepatocytes which harbor hepatitis B virons. Again, it is chronic phase, so the surface antigen has to be positive and anti-HBs has to be negative. E antigen is positive here and the HB is negative. The same is the total antibodies, but here you see, now the DNA starts decreasing. The reason, because now the viral replication is being controlled by the immunity, and because of the immunity is attacking hepatocytes, there's liver damage, the hepatocytes damage, and LT is raised. So the only difference between these 2 phases is that the ALT is raised here, while LT is normal in the immune tolerant phase, and the viral load is very, very high here, whether it is decreasing now because now the immunity is controlling the HBV infection. Okay, so because E antigen is positive in these 2, this is called HBe antigen positive infection because it is normal, and this is called HBe antigen positive hepatitis because it is raised here and inflammation has set in by the immunological attack on hepatocytes. So when this continues and goes on, a time comes when the viron replication is controlled and almost controlled to the 0 level. So in the immune control phase, what happens when the viral replication is very much controlled, either 0 or less than 1000, the LT becomes normal because now the inflammation has cooled down. And as a result of this immunological attack, the E antigen becomes negative, there's seroconversion, and E antibody will be positive. Rest remains the same. So this is called HBe antigen negative infection. Why we call infection? Because ALT is normal and there is no inflammation. A time comes that this virus escapes the immunological control, and what happens, the ELT, the viral replications increases, the viral load increases, and then the immunity again becomes awakened, attacks those hepatocytes where the replication has started, and second sets of inflammation sets in, and the ALT is rising. So this is called HBe antigen negative hepatitis. So we learned the acute and the recovered phase, and in the chronic phase, chronic hepatitis, 4 phases, HBe antigen to first 2 HBe antigen positive, last 2 HBe antigen negative. And in HBe antigen positive, the first phase was of just infection where the LT was normal, and the second phase was hepatitis or inflammatory phase where LT was raised. Similarly, HBe antigen negative phase, the first one was the infection with normal LT, a second was inflammation or hepatitis. So this is the way when a patient comes into chronic phase, these are the 4 phases the patient follows. What about if the patient had never this hepatitis B infection? What will be his or her serology? That will be HBs antigen will be negative. If the patient has been given vaccine, so if the patient has been given vaccine, his surface antigen will be negative, but the anti-HBs will be positive because you have vaccinated him and the body has made vaccine against the antibodies against that. But here the rest of the E antigen, E antibodies, total antibodies, DNA, everything will be negative. Okay, so this is important we understand whether my patient is HBV vaccinated or not, and if the patient had infection, which phase the patient falls in. Okay, so what does HBV serology tells us? HBV serology by standards or by common understanding, these 3 are the HBV serological tests: HBs antigen, anti-HBs, and anti-HBc. HBs antigen tells if the patient has got active infection, and if it is, whether this is acute or chronic. It may be anyone, acute or chronic. Anti-HBs means immunity, whether this immunity is because of the vaccination or is because of the patient was infected and now recovered. And anti-HBc means whether the infection is current, still it's current, acute, or it was post-infection or the long-term infection. So the serology tells us, has patient immunity against HBV? No. Or yes, or if yes, it is because of the post-infection or HBV vaccine. And if a patient has current infection, no or yes, if yes, whether this is acute or chronic. And now I will share the different scenarios with you how it tells us. If the HBs antigen is negative, anti-HBs is also negative, anti-HBc is also negative, when all these 3, 1, 2, 3, when all these 3 are negative, the color is light blue, it means the patient is susceptible to get infected and now consider vaccination. Especially those patients who are having any family member of HBs antigen positive, or whom by profession like doctors, dentists, those, the phlebotomists, or the lab workers who can get infected, so they must be vaccinated. Coming to this, if the out of these, if the HBs antigen positive and the core antibodies is positive, but anti-HBs is negative, it means the patient has got HBV infection. If the IgM antibodies is positive, this will be acute. But if the total is positive, this will be chronic. So this is the second scenario where the serology tells us where my patient is. Coming to this, if HBs is negative, core antibodies is also negative, but it's anti-HBs positivity, it means the patient is immune because of the HBV vaccination. So this is the third scenario. Fourth scenario will be that patient out of these 3, HBs antigen is negative, but anti-HBs is positive, and anti-HBc is also positive. So it means it is immune due to resolved HBV infection. And if only HBC is positive, HBs is negative, the anti-HBs is also negative, it means either this is distant resolved HBV infection, or this results may be false positive, or resolving acute HBV infection may be there, or the passive transfer of maternal and anti-HBC to the fetus and to the child has happened, or this may be occult hepatitis B infection. Occult is that when the HBs antigen is negative, but because of the CCC DNA is there, so that is called occult. And if the PCR becomes positive in that case, that is another indication for the treatment. So what I told you, this picture, this is very, very important, that depending upon the antigen and antibody status, you can put your patient, whether my patient is in acute phase or recovered phase and are in chronic phase. If the patient is in chronic phase, either this is the immune tolerant or immune reactive or immune control or immune escape, or the patient is completely recovered. So this is very important slide, and you should, and if you know, and if you keep this in your mind, then you can easily put your patient into phase. If the patient is in immune reactive phase or immune escape phase, this is the phase where the patient will need treatment. But if the patient is in immune tolerant phase or immune control phase or past infection, these patients do not need treatment. Acute hepatitis B, by default, we don't treat them with antivirals unless it is indicated. That will be the scenario which Altaf Saab will be telling with you, discussing with you, but it will be a very peculiar scenario. Okay. So with this background, as I told you, that the take-home points are that now the chronic hepatitis B has been divided into two main phases. First is HBe antigen positive phase, or HB antigen positive patients, and the second group is HBe antigen negative patients. The HBe antigen positive patients in past, they were either in the immune tolerant phase or immune reactive phase. Nowadays, the immune tolerant phase is called HBe antigen positive infection. And the immune reactive phase is called HBe antigen positive hepatitis. And the HBe antigen negative patients, they are divided into two: immune control phase or immune escape phase. Immune control phase is called nowadays E antigen negative infection. And immune escape phase are called nowadays E antigen negative hepatitis. And I have discussed with you and told you why it's infection or hepatitis. And all these PCR may be positive, and PCR is positive. Here it's very high viral load. But as the immunity is sleeping, not attacking on the hepatocytes, so there is no hepatocyte damage. There is no set of inflammation. That's the reason it is called infection, and you should not treat this phase if the ALT is normal. But if the immunity attacks on those hepatocytes or infected hepatocytes, there will be hepatocytes damage, ALT will start rising, and the viral load will be going down. So this is the phase when there's inflammation. And I told you, if you do not shorten the duration of the inflammation, this inflammatory phase, inflammation phase may stay there for years, even for decades. And longer the duration of the inflammation, higher will be the chances of fibrous tissue deposition. And the more the fibrosis will be, higher will be the chances of cirrhosis and then its sequelae and hepatoma. So that's the reason when the patient is in this phase, when the immunity has become active and attacking the hepatocytes, you treat these patients with antivirals, so you shorten the duration of these immune reactive phase, and you push this patient from immune reactive to immune control phase. And then you follow this patient. You follow these patients regularly if the patient is developing this immune escape phase or developing E antigen negative hepatitis. And if it happens, you will treat this patient. Well, so the take-home point is that when a patient is HB antigen positive, comes to your hospital, to your clinic, to your outdoor, First of all, we look for the acute hepatitis features, that is the sclera, yellow scleras and the yellow skin, the features, clinical features of acute hepatitis. If there are no features of acute hepatitis, this is then chronic hepatitis B infection, or chronic HBV. I won't call it infection to make it more clear. This will be chronic HBV, not acute hepatitis. So now it depends upon the liver status. If the liver is normal, or the liver is fibrotic, or the liver is frank cirrhotic. So we need to determine whether my patient is having normal liver, or fibrotic liver, or cirrhotic liver. So if the patient is having normal liver, then those 4 phases, they matter. And I told you the serology will tell us whether my patient is an HBe positive infection, or HBe positive hepatitis, or HBe negative infection, or HB negative hepatitis. So here the serology will mostly determine whether my patient needs treatment or not when the patient liver is normal. But if the patient liver is fibrotic, either by ultrasound, coarse ecopatron, or by FIB4 or EPRI testing or fibroscan, then even the qualitative PCR will suffice to start the treatment. In fibrotic liver, even if the qualitative PCR is there, you will start treatment, the patient treatment. In this phase, Professor Altaf Alam Saab will be discussing with you what are the different cutoff values where you will treat these patients. And if the patient is cirrhotic, at times in decompensated cirrhosis, even at centers, the patient is started on antivirals, even with negative PCR, for the reason to prevent the reactivation. At any time, it can be reactivated. So this is very, very important. If the patient is HBs antigen positive with no features of acute hepatitis, the patient is in chronic HBV state, and you need to determine the liver status, because the liver status is the determining factor for treatment. If the liver is normal, then the serology will come to play. So HBs antigen positive patient comes to you. What you do in the first phase, we don't do PCR in each and every patient. What we do serum ALT, ultrasound, EPRI, and FIB4. EPRI, FIB4, these are simple parameter-based smartphone calculators. And what you need, ALT, AST, platelet count, and the age. So if the serum ALT is normal, as well as EPRI is less than 0.05, FIB4 is less than 1.5 or less than 1, ultrasound is perfectly all right. There is no cortical pattern, there is no splenomegaly, there is no dilated portal vein, there is no ascites. So this is a patient, either the patient is in the HBe antigen positive infection phase or HBe antigen negative infection phase. So you need to consult this patient and do the follow-up. Even if you don't do the PCR here, with all these parameters normal, you won't lose anything. Because doing PCR means spending money from the pocket of the patient. But if the ALT is more than 2 times normal, the EPRI was more than 1.5, FIB4 more than 3.5, and ultrasound showing either chronic liver parenchymal disease or frank liver cirrhosis, no, this is the group of the patient. Any one parameter, not necessarily all 3. In this group, all these 3 should be green, should be normal. The ALT, EPRI, FIB, ultrasound, all these should be okay. Here, any parameter, patient with ALT more than 2 times normal, or the ALT is normal, but there is FIB4, FIB is more than 3.5, EPRI more than 1.5, or even if the ultrasound is anyone, if anyone is abnormal, this is the group where you will do HBe antigen, anti-HBe, and HBV PCR, either qualitative or quantitative, depending upon the liver fibrotic status. And here the serology will come, whether my patient is in immune, the positive infection or hepatitis or infection or hepatitis. So this is the way we go for interpreting these serological tests and picking up those patients who are in the need of treatment and who needs to be treated and then carried on the treatment. So I tried to discuss with you the simple interpretation of the HBV serological tests, because unless we know the baseline, that where our patient lies, whether it is in the acute phase or the chronic phase, and if it's in the chronic phase, whether my patient HBe antigen positive or negative, and after determining positive or negative, then we have got two other sets, the infection phase or hepatitis phase. And if my patient is in hepatitis phase, I will start the patient on treatment, or refer the patient to some other center for treatment. But if my patient is in the infection phase or the recovered phase, we won't treat this patient. So here I stop my lecture and discussion, and the mic is over back to the Uzair for any other thing.
Thank you very much, sir. You have covered the topic very comprehensively. Dr. Raj, we do have a case. Are you with me?
Uzair bhai.
All right. Can you see my screen?
Can you hear me?
Yes, I can hear you. Please go on.
Okay. Should I read?
No,
I'm going to start presenting the case now.
Please.
Can you hear me, Uzair?
Yes, we can hear you.
It's a 45-year-old male presented in OPD with HPS antigen positive, which was an incidental finding. He had no active complaint, non-diabetic, non-smoker, non-hypertensive. He had no history of surgery or blood transfusion, history of frequent visits to dentists, no history of ascites or encephalopathy. His lab investigations are as given below. HB was 14.9, platelet 256, ALT 36, and AST 35. Bilirubin was 1, and albumin was 3.9, gamma GT 26, and creatinine was 0.7. His AFP was 2, and PTINR was 12 by 1.2. His EPRI was 0.4, and his serological test showed HBS antigen positive, HBe antigen was negative, and anti-HBe positive. Anti-HCV was negative, and anti-HIV 1-2 was negative. Anti-HTV total was negative. His HPV DNA by PCR was not detected. On ultrasound abdomen, Zerbe, can you? His ultrasound abdomen was normal, liver ecotexture, no ascites or SOL. On fibrosis, it was F0 to F1 Metavis score. The questions are: how will you interpret his investigations, and how will you manage and counsel this patient?
Okay, thank you very much. Yeah, can you just bring the, yeah, it's okay now. Yeah, thank you. So it's a very good scenario and everyday scenario. And when we take our patients of chronic hepatitis B, our patients coming to us with HBs antigen positive test in their hands, this is the most common scenario which we come. If you remember just a few minutes ago, I told you if this is the whole picture is there. So just I'll link that scenario with my talk, and then I'll answer those two questions. That said, the patient has got HBs antigen positive and chance finding and no clinical features of acute hepatitis like here. So what I said that we will do ALT, we will do the EPRI and FIB and ultrasound. You see here, the ultrasound, the ALT is normal, that is 36. The EPRI is less than 0.4. I said if it is less than 1 or 0.5, it's okay. And the ultrasound is also normal ecotexture, no ascites, no SOL. So I told you that if this is the parameter, my patient is either lying in the HBe antigen positive infection phase or HBe antigen negative infection phase, and probably my patient will not need any treatment. So here, when they have done the further workup, what we see that my patient is E antigen negative and E antigen positive, antibodies positive. It means out of the second phase, the second step was whether my patient is E antigen positive or negative. Here my patient is E antigen negative patient. So HBs antigen positive and E antigen negative. Then furthermore, two main possibilities. Either this is the HBe antigen negative infection or HBe antigen negative hepatitis. In infection, LT has to be normal and PCR has to be negative or less than 1,000 copies. What we see here, the ALT is normal and the PCR is negative. So my patient is lying in HBe antigen negative infection or immune control phase, or in past we used to call this HBs antigen carrier. Okay, if the PCR was positive, would have positive here and LT would have raised here, I would have said that my patient is in HBe antigen negative hepatitis phase. Okay, so with this parameter, my patient is in HBe antigen negative infection phase. And as I told you that in the last algorithm, that please you show me the two questions. So I want to link up to that. Now come to the questions, please. Yeah. So I told you that if my patient is in HBe antigen negative infection or even HBe antigen positive infection phase, the patient needs counseling and follow. The same is here. So as I interpreted with you, my patient is the immunity has controlled the infection and now the infection is cooled down, PCR is negative. So I need to follow up this patient, counsel this patient that you see your immunity has controlled your infection, but there is a chance that this infection may come out of the immunological control and your PCR may become positive, and that will be a time when we will treat you. So for the patient, this will be one thing, and the family, that we need the patient follow-ups. Though the liver is normal with no fibrosis or F1 fibrosis, if the fibrosis would have been high, we would have thought that maybe we will treat this patient even with the negative PCR, but this is the normal liver, but still the patient needs follow-up for liver status worsening. There is chance of hepatoma, though very low, very meager, just next to the common population, but still these patients need to be followed for the HBV related reactivation, liver worsening, as well as hepatoma. But the most important point is that vaccination of the family members, vaccination of the spouse, and he should be trying to prevent spread of this infection. So this is very important that the patient understands that I have been naturally controlled, but I need to have the follow-ups and I need to vaccinate my family members, and I need to adopt the measures not to spread to the others. So this is the most common scenario, and what we have seen, unfortunately, that even with the negative PCR, patient has been started with the treatment, and then nobody knows how to do with that. So as I said before in my very first slide, in hepatitis B, don't start antiviral treatment unless it is indicated. In hepatitis C, treat patient unless it is contraindicated. So these are the two converse of one another. Thank you very much. This was my reply to this, and very excellent scenario. And I hope that our colleagues may have some questions regarding this or other scenarios. So I'll be more than happy to take those questions.
Yes, the house is open for questions now. You can raise your hand or you can unmute yourself for any question. We do have a question in chat, sir. It's all right. It's from, kindly wait a moment, please. What if the patient has ALT is between 30 and 50? What we will consider it normal or high?
Okay, yeah, I saw this question. You see the upper limit normal of the ALT has been a question of debate quite long for abroad in America and Europe and puzzle as well. So what the Americans they take the 30 for the male and 19 for the female to be normal, and anything more than that, it's abnormal. In a puzzle and even in Pakistan, here I'll be discussing about Pakistan. By and large, this is the 40 to 45. Around the 40 is we take this upper limit normal, and here we really don't distinguish between the male and female values unless when there is the patient has got the cortical pattern, or where the patient is high risk patient, then we may, case to case lower down. But 40 is on average. I'm not saying, but on average, this is taken as the normal value here in Pakistan. And for the treatment purpose, it should be twice the normal. At least it should be more than 80. To my patients, what I say, I make it even 100. That 100 is a figure which is remembered. So I tell them, if your ALT is persistently more than 100 on 2-3 occasions, this is the time when you come. So, but the 2 times normal is taken in the guideline. The 2 times normal is when the patient, if the patient has got more than 2 times, either the patient is in the E antigen positive hepatitis phase or E antigen negative hepatitis phase.
All right, one more question in the chat. Which level of high ALT needs treatment?
Yeah, this is I just answered. More than 2 times.
Okay. So we just have comments over here. So all right, you can raise your hand or you can unmute yourself if there are any questions. Anybody?
Yes, I have a question.
Yes, sir, I have a question. What are indications of treatment in acute hepatitis B?
Well, I traditionally left this questions for our next lecture by Professor Altaf Alam. But in a short, when there is impending encephalopathy, then you treat these patients with antiviral. When you think that the patient is going into acute liver failure, but mind it that the studies have shown that those where you have treated them with the antivirals, the going into chronic phase is higher as those where they, left and followed like that. So unless there is the acute liver failure and really going worsening, never treat these patients with the antivirals, because these are the patients that you will control the patient's infection, but you will probably not make them PCR negative, and they will go into a chronic phase, immune tolerant phase, and all those things.
All right, thank you very much, sir. A quick question from Dr. Yawar Abbas. Sir, I am going to unmute yourself. Please ask your question. Dr. Yawar Abbas, please carry on.
Hello, Assalamu alaikum, sir.
Wa alaikum salam.
सर क्वेश्चन ये है कि ये इम्यून रिएक्टिव फेज में आपने कहा है कि ई एंटीजन एंटीबॉडी एंटी-एचबीएस एंटीबॉडीज और कोर ये सब नेगेटिव होंगे, देन व्हाई इट इज कॉल्ड इम्यून रिएक्टिव फेज?
नहीं, मैंने नहीं बोला। देखें आप अगर हम बोलते हैं ना कि ये पेशेंट क्रोनिक हेपेटाइटिस है, तो उसमें तो बाय डिफॉल्ट चारों के चारों फेजों में एचबीएस एंटीजन तो पॉजिटिव होगा, ठीक है ना। जब हम बोलते हैं क्रोनिक हेपेटाइटिस बी, इसका मतलब है कि एचबीएस एंटीजन ने पॉजिटिव रहना है चारों के चारों फेजों में। और हम बेसिक इम्यूनिटी से जानते हैं कि अगर एंटीजन पॉजिटिव है तो एंटीबॉडीज ऑटोमेटिकली नेगेटिव होगी। ये हो ही नहीं सकता कि एंटीजन और एंटीबॉडीज दोनों पॉजिटिव हो। मैं ब्रॉडली आपको समझाने के लिए बोलता हूँ, ठीक है। इसके बाद फिर हमारे जो पहले 2 फेजेस हैं उसमें ई एंटीजन पॉजिटिव है, और आखिरी के जो 2 फेजेस हैं उसमें ई एंटीजन नेगेटिव है, ठीक है। जब हमारा ई एंटीजन पॉजिटिव होगा तो ऑटोमेटिकली हमारा ई एंटीबॉडी नेगेटिव होगा, और जब आखिरी 2 फेजेस में हमारा ई एंटीजन नेगेटिव हो जाता है तो इसलिए हो जाता है कि ई एंटीबॉडीज आ गई है, सीरो कन्वर्ट हो गया। ये भी सिंपल हो गया। अब जो मैंने इम्यून रिएक्टिव फेज बोला था, इम्यून रिएक्टिव फेज में क्योंकि इम्यूनिटी अब उन हेपेटोसाइट्स पे अटैक कर रही है कि जिनमें हेपेटाइटिस बी वायरस है और सारे ही होते हैं, उस वजह से वो हेपेटोसाइट्स दे आर अटैक एंड दे आर किल्ड, दे आर डैमेज्ड। और जब वो डैमेज होगा तो होगा क्या कि उनकी एलटी राइज करना शुरू हो जाएगी, इन्फ्लेमेशन शुरू हो जाएगा, और जब वो हेपेटोसाइट्स मरने शुरू हो जाएंगे तो साथ में cccDNA में वो चीजें भी जो है ना वो करनी शुरू हो जाएंगी। तो होगा क्या कि एचबीएस तो उसने पॉजिटिव रहने, ई एंटीजन भी अभी पॉजिटिव है, ठीक है, लेकिन जब एटी राइज करेगी और वायरल लोड ऐसा कम होना शुरू हो जाएगा, और जब उस एक्सटेंट तक जाएगा कि तमाम के तमाम वायरल लोड को या तमाम रिप्लिकेटिंग वायरल को उसने कंट्रोल कर दिया, सिर्फ cccDNA रह गई, तो इन्फ्लेमेशन अब कूल डाउन हो जाएगी, क्योंकि अब जरूरत नहीं हुई जितने पेटोसाइट से जिनमें वायरल था वो अटैक हो गए, वो डिस्ट्रॉय हो गए, वो किल हो गए। मैं आपको सिंपल समझाता हूँ, एग्जैक्टली ऐसा नहीं होता लेकिन सिंपल समझाता हूँ। तो होगा क्या कि आपकी एलटी भी नॉर्मल हो जाएगी, और वो ई एंटीजन जो पॉजिटिव था, क्योंकि अब वो सारे कंट्रोल हो गया, अब सीरो कन्वर्ट हो गया। तो आखिरी दो फेजेस में ई एंटीजन नेगेटिव हो जाएगा, लेकिन ई एंटीबॉडी आ जाएगी, क्योंकि एंटीबॉडी के जोर से ही वो नेगेटिव हुआ है, ठीक है। तो मैं वो शायद वो जल्दी में कह गया था, या फिर वो स्लाइड शायद आपने फॉलो नहीं की, वो स्लाइड शायद आप शेयर कर लेंगे उजैर भाई। हेपेटाइटिस बी क्रोनिक फेज में चारों के चारों फेज में एचबीएस एंटीजन ने पॉजिटिव रहना है, ई एंटीबॉडीज ने नेगेटिव रहना है। फर्स्ट फेजेस में ई एंटीजन ने पॉजिटिव होना है, लास्ट फेजेस में ई एंटीजन ने नेगेटिव होना है, और इसके बाद एलटी अगर रेज्ड है तो हेपेटाइटिस है, नॉर्मल है तो इन्फेक्शन है, रेज्ड है तो हेपेटाइटिस है, नॉर्मल है तो इन्फेक्शन है। अगर एलटी रेज्ड है ट्रीट करें, एलटी रेज नहीं है ट्रीट ना करें, सिंपल।
Thank you very much, sir. There is a question in the chat. 95 years old lady, HPSAG positive, with ALT of 114, no other workup done. She was started on tenofovir by a doctor. What's your opinion?
ये एक पर्टिकुलर केस है या सिनेरियो है, तो बेसिक्स वही चीज है कि अगर इस लेडी की एलटी रेज थी, ठीक है, तो हमें अगर सिर्फ एलटी रेज थी और 2 टाइम्स ज्यादा रेज है तो हमें इसका प्रोफाइल कर लेना चाहिए था, क्योंकि एलटी जरूरी नहीं है कि हेपेटाइटिस बी इन्फेक्शन की वजह से रेज हुई हो। अगर ये 95 जो लेडी है, मोस्ट प्रोबेबली चांस है कि ये शायद एचबीएस के वो होगी, कंट्रोल फेज होगी या केयर टाइप चीज होगी, मे बी एलटी रेज होने के कुछ और वजूहत हैं। तो जो वर्क डन नहीं हुआ है ये थोड़ी सी अनफॉर्चुनेट है इस केस में, क्योंकि जो मैंने लास्ट एल्गोरिथम यही बोला कि एलटी में या FIB4 एप्री में या अल्ट्रासाउंड में कोई भी एबनॉर्मल हो और या तो एलटी मोर देन 2 टाइम्स थी, तो लाजमी हो जाता है कि आप प्रोफाइल करेंगे, ई एंटीजन भी चेक करेंगे, ई एंटीबॉडीज भी चेक करेंगे और पीसीआर भी चेक करेंगे, और अल्ट्रासाउंड तो वो भी कोई डेटा नहीं है। तो इस पे मैं क्या कह सकता हूँ, ये कह सकता हूँ कि अगर शुरू हो गई है तो अभी भी उसका करना चाहिए, ये प्रोफाइल वगैरह करनी चाहिए, देखना चाहिए, क्योंकि एचसीवी की तरह नहीं है कि एचसीवी में आप ट्रीटमेंट शुरू करो 1 महीने के अंदर अंदर पीसीआर नेगेटिव होता है। एचबीवी में कभी पीसीआर 1 महीने में अंदर नेगेटिव नहीं होता, बल्कि महीनों सालों लगते हैं इवन की पीसीआर नेगेटिव होने में। तो अगर ये पीसीआर नेगेटिव आ जाती है, ई एंटीजन नेगेटिव आ जाता है, लिवर नॉर्मल है, तो शायद कोई और वजह होगी। और मेरे ख्याल में इस पेशेंट्स को फिर शायद टेनाफोविर की भी जरूरत नहीं होगी। अगर इन केस इसको एंटीवायरल की जरूरत भी है तो 96 ईयर्स एज पे अल्ताफ साहब आपको बताएगा कि फिर टैफ या टीडीएफ पे जो टेफ ज्यादा चाहिए, बेहतर रहेगा, एंटाकवर बेहतर रहेगा, वो फिर आपको बता देंगे उसमें। लेकिन इसमें मेरा यही आंसर होगा मैं अपने शाहबुद्दीन भाई के लिए।
Thank you, sir. We still have 2 minutes left. A quick question from Dr. Abdul Haseeb Saab. Sir, I am going to unmute you. Kindly go on with your question. Dr. Abdul Haseeb. Dr. Abdul Haseeb Saab, are you with us? All right. A quick comment.
Yes, excuse me.
Okay, carry on. Go on, please.
Sir, I have a question for you, sir. You said that whenever an antigen has to be positive, then antibody has to be negative. So in acute hepatitis B, when the HBS antigen and HBe antigen is positive and their respective antibodies are negative, then why the HBC antibody, that is core antibody, is positive? Thank you.
Ji, you see, I tried to make the things simple for you, and that's the reason I didn't go into the very depth of the immunology. Any antibodies which appears, it appears as IgM, And when long term, the IgM changes into IgG. This is very basic immunology. Okay. And when the antigen is there and the antibodies is formed, not on the first day of the formation of the antibodies, the antigen goes down. This is one thing. Okay. The core antigen, we haven't been able to detect that in the labs. This is, you all know that. We cannot detect core antigen. We detect only antibodies. Okay. So when you follow these patients, such patients, a time comes when the antibodies level will be, titer will be increasing, the antigen titers will be decreasing, and then it is at the parallel level, and then it goes down, and the passage of time, it becomes, the antigen becomes zero, and antibodies stays to some level, and then it has got plateau. Okay. So in acute hepatitis B, the typical scenario is that the HBS antigen is positive, E antigen is positive, and IgM core antibodies is positive, and PCR remains positive. We never do PCR in acute hepatitis B phase. A time comes that the HBS antigen has appeared, but it has not been detected, and the surface antigen goes down. You don't see surface antigen, you don't see anti-HBS, but you see only IgM, core IgM, and this is called window period. Okay? So I didn't go to that depth of the immunology, but we haven't been able to detect the core antigens. So we detect we say about the patient has got the core antigen, was having, because antibodies is appeared. But when you take the biopsy and check on that, so in the tissue biopsy, you will be able to detect the core antigens. Okay.
Thank you, sir. Thank you.
Thank you.
Okay, thank you very much, sir. It's just about the time. We have 2 questions left. So your quick comment on that. Cirrhotic patients secondary to HCV leading to esophageal varices, which is band ligated. Is it important to treat the patient with antivirals?
Yeah, you see, the HBS antigen is, the patient is liver cirrhotic because of HBS or HBV related liver cirrhosis. And if the patient has developed the varices, this patient should be treated, but it should be followed very closely. We treat this patient to prevent reactivation. Even if the PCR is negative, we treat them to prevent reactivation, but it should not be treated in a primary level. The patient should be handed over to the high volume center or high experienced people, because the antiviral related toxicity may happen. So, but technically this patient should be treated to prevent the reactivation, because this is a cirrhotic liver. If the base antigen reactivates, HBV infection reactivates, it will really result in acute on chronic liver failure, and the patient may die. So this patient doesn't qualify for the treatment.
All right. There is a request for comment on pregnancy and safety of antivirals by Dr. Sameer Ahmed. We do have a complete session on upcoming session on that. So it would be better.
I'll just give 5 seconds of answer. Tenofovir, the TTF, is the only drug safe for pregnancy. Simple answer. Entecavir should not, and TAFE, no data of the safety available yet. So tenofovir, TDF, is the only safe drug.
All right, thank you very much, sir. A last quick comment from Dr. Ali Haider from Larkana. Sir, I'm going to unmute you kindly. Dr. Ali Haider sahab.
जी अस्सलाम वालेकुम to everyone. अस्सलाम वालेकुम to Farooqi साहब. मजा आ गया, बहुत मजा आ गया. Really बस ये कहना था. Every time different type of presentation from other presenters. So from basic to advanced. Thank you very much. Jazakallah.
Thank you very much.
Thank you very much. My apologies for not taking Dr. Samiullah online. So at the end, it remains on me for thanking Professor Javed Iqbal Farooqi Saab and all of you for attending this wonderful session. Our next session would be on HPV, whom to treat and how to treat, by Professor Altaf Alam on the 2nd of September 2020. Till next time, Allah Hafiz, and thank you very much to all of you for joining this session. Khuda Hafiz.
Khuda Hafiz.